Society of Iran. From the Philippines, we have Dr. Helen de Guzman and Dr. Marita Reyes. Their research is sustaining gains in community engagement in the study on gender responsiveness in TB prevention management in the high TB burden urban area in the Philippines, promoting enablers and overcoming barriers. We also have Dr. Phyllis Awor with the research community engagement and social innovation, a mixed methods analysis from the Social Innovation in Health Initiative. From Kazakhstan, we have Dr. Bakit Maskova with the Research Mapping Ethics Committee, IEC IRB practices in engaging communities in health research in Eastern Europe and Central Asia countries, social innovative models for implementation, and transferring the results of TB-related research. From Cameroon, we have Dr. Claudine Akondeng with the research Rethinking Meaningful Community Engagement in Research in Cameroon and Senegal. And finally, we have Dr. Zudi Berhanu from Ethiopia with the research Identification, Synthesis, and Translation of Good Practices and Evidence for Engaging Communities in Research and Social Innovation in Healthcare Delivery for Infectious Disease of Poverty in Sub-Saharan Africa. So a warm welcome to everyone who is here with us, both in YouTube and in Zoom. Welcome to our event entitled A Showcase of Social Innovations in Health, the SIHI Asia Hubs Experience. So I'm very excited to learn more about the different social innovations that have taken place in this side of the world in Asia. So for those who are joining us via Zoom, I would like to remind you to, your microphones are already on mute, and please prevent yourselves from clicking the video so that we will be able to save on bandwidth. So if you have questions anytime during the event, please feel free to type them in the chat box or in the comments section for our viewers in YouTube. Okay, so for today's session, we will have two parts. Next slide, please. The first part will showcase the different social innovations that took place in Asia with a commentary or reaction by our experts from SIHI and TDR. For the second part of the program, we will be learning the following. First is identifying social innovations through crowdsourcing open calls. Next slide, please. Methods and processes by Dr. Wei-Ming Tang. And then it will be followed by a talk on co-creating social innovations through implementation research by Dr. Yodi Mahendrata. And for our third speaker, she will be talking on embedding social innovation in research and research in social innovation, the SI monitoring and evaluation framework checklist. This will be presented by Dr. Liz Chen. So to formally open our event, I would like to call on the TDR Program and Portfolio Manager, the co-founder and lead of Social Innovation for Health Initiative, Dr. Beatrice Halpaap. Dr. Beatrice.
Hello, thank you so much, Carissa. So hello to everyone, and a warm welcome to all of you. And it's very exciting today to actually hear about the experience of the hubs in Asia, and as well as the other hubs coming in and reacting. I think it's a really, really interesting approach that will be very stimulating, and having some more about all the monitoring and evaluation of the crowdsourcing. So very, very rich event, and very pleased to see this happening. So my name is Beatrice Halpaap. I'm an expert advisor on global health, and I'm very interested in equity and community engagement. And I'm co-founder, yes, of SIHI, and also work as lead for SIHI for TDR, the special program of research and training in infectious disease, which is co-sponsored by WHO, but also UNDP, UNICEF, and the World Bank, and hosted in WHO. And on the name of TDR and of SIHI, we'd like to really welcome all of you. We're very pleased also to have joined some of great supporters, and I'm thinking in this all the other co-founders from South Africa, the Bertha Center, or from the London School with Rosanna Pilling, from SIDA as well, from Hannah Kufo, I think is joining or will be joining. So all of those champions that made it happen, and without forgetting one of a key champion in Asia, Marianne Langsam, who together then with Noel and now Meredith are moving this forward. So warm welcome to all of you. Warm welcome specifically to you all who have been awarded a grant from TDR to identify good practices of community engagement in research and in social innovation. This is going to be really interesting as well to have you engage and understand better what SIHI is doing and what social innovation can be. And yeah, let it just happen. Thanks very much to the SIHI Secretariat who has organized this event, and to all of you who are participating and contributing. Thank you. Over.
Thank you very much, Beatrice. Thank you for that, sharing with us, of course, your background and social innovations, and of course, the unique, the endless opportunities that we have through social innovations. Okay, so to proceed, next slide, please. Social innovations have been taking place in our communities for a long time, and it's a response to provide the solution to the pressing need or concern using the community's resources, capitalizing on individuals' talents and abilities. Creativity brews innovation, leading to an appropriate solution, addressing root problems and concerns. For today, our presenters or innovators have shown such qualities within their respective organizations. They have responded to the call of their communities and have shown outstanding results. They have been recognized by different awarding bodies, and we're privileged to hear their stories and apply their learnings today. So, next slide, please. SIHI India Hub has been recently established, and early this year, it has led its first nationwide call for solutions, dubbed as SIHI India Healthcare Excellence Award, a recognition of social innovation and health impact creators. The projects of Pushy Baby and Save Mom were awarded, both of which were innovatively working to reduce maternal and child mortality rates in India. So the first to present is Pushy Baby. The state of Rajasthan in India struggles with a high maternal and child mortality rate. So in this modern age of digitalization, Pushy Baby utilizes a modern day technology platform to address this problem. May I call on Dr. Sashi Dalal and her team to tell us more about it.
Hi. Sorry, I'm just trying to share my screen.
Go ahead.
Hi. Are you able to see my screen?
Yes.
Hi, everyone. So I'm Sachi, and I work on research and strategy with Cushy Baby. So Cushy Baby is a digital health nonprofit working as a technical support partner to India's largest state. And today I'll be sharing about how the pandemic became an inflection point for us to reach new levels of impact. So in rural India, traditionally, beneficiaries hold paper health cards and health workers maintain paper health registers, and they manually mobilize beneficiaries to come for preventative care. With Cushy Baby, beneficiaries receive a portable digital health record, and health workers get a mobile app which can instantly read and update the medical history with decision making support. And beneficiaries get automated voice calls in their local dialect to give them awareness reminders and health checkup reminders. Health officials are also empowered through analytics that we provide on our dashboard. In rural areas with poor internet connectivity, Cushy Baby system works completely offline. So how did we get here? We started our mission in 2014, looking to improve infant vaccination rates. Our journey started at Yale Center for Engineering Innovation and Design and took us to rural Rajasthan, where we learned about challenges health workers and beneficiaries face on a daily basis. In Rajasthan, 40 out of 1,000 children do not make it to their first year of life, and there are 420,000 high-risk pregnancies annually. Deep human-centered design work uncovered the burdensome paper-based processes and siloed health applications. It powered the creation of our digital health solution for supporting maternal and child health. After a 2-year randomized control trial, we brought evidence to the State Department of Health showing that our digital intervention could improve process and health outcomes. Through advocacy, we were able to use our innovation to affect system level change, ultimately being selected in the role of technical support partner to the Department of Health to scale up our solution 7 years later. In 2020, 2 months after receiving word that our platform for maternal and child health was selected for scale up, COVID-19 reached India and the department's priorities shifted. We had a tough choice to continue to build out maternal and child health components core to our mission or to adapt our solution to the new pandemic priorities. Ultimately, we knew that the department was our vehicle to achieving impact, so we shifted our paradigm to focus on primary care and the pandemic. In 2 months, we had built a new mobile application that could work on hundreds of mobile phones, learn new modalities to train tens of thousands of health workers, and develop a process to support and build capacity of both health workers and health officials to respond to the new data. Our platform has made impact at scale. 60,000 health workers have used our solution to track the health of 14 million beneficiaries across Rajasthan, the largest deployment of its kind in India during the pandemic. So how was this possible? We removed features from our original platform to improve scalability and compatibility. We deployed our platform on the state's secure data center. We used Project Echo in training of trainers models. We joined over 200 WhatsApp groups of community health workers across the state. We made a road trip across the state, visiting over 10 district chief medical officers, and visited the health secretary every day during the lockdown. The platform and services to the government have always been free of cost. Our platform expands beyond COVID-19 to include other infectious and non-communicable diseases. Now, health stakeholders have unprecedented village-level insights of hotspots and respond by deploying local health camps and other resources. We're currently working to expand the solution to include and integrate other primary healthcare verticals beyond reproductive and child health, as per national guidelines, so that health workers in the referral route has a single unified interface for tracking patients and reporting community health outcomes across verticals. There are over 1.25 million community health workers that we aim to reach in the next 5 years as we push to make this platform a standard for the Government of India's Ministry of Health. We are a team of 38 members, local public health practitioners, developers, and data scientists who ensure end-to-end delivery of this digital health platform. We are actively looking to grow our team as we scale our work across India. And we are working with world-class partners, and we invite you to join us. Thank you.
Thank you very much, Sachi, for your presentation. We really appreciate the initiatives that you have taken to decrease child mortality, especially in the biggest state in India, which is Rajasthan. All right. So to proceed, we will be calling out Save Mom. According to the National Health Portal of India, about 20 to 30% of all pregnancies are categorized as high risk, 75% of which can lead to perinatal morbidity and mortality. Save Mom focuses on these threats and provides maternal care by using an artificial intelligence-enabled telemedicine software. So for us to learn more about this, may we call on Mr. Senthil Kumar and his team to share more about Save Mom.
Hello everyone. Thank you so much for the opportunity. Myself, Senthil Kumar. I'm just starting the presentation. Hope the presentation is visible. Myself, Senthil Kumar. So our product is Save Mom. At Save Mom, our main objective is to provide personalized home care for pregnant mother throughout the 1,000-day period with the help of using AI and IoT-enabled telehealth solution. So we are globally recognized company, received award from including SIHI and then WHO and Nobel Prize team. We were supported by the industry leader Facebook and Google for our innovation. And yeah, this is the main problem we are solving. As per the WHO, every mother has to go minimum 8 antenatal checkup to have a positive pregnancy. But in India, mothers take less than 2 antenatal checkup. The main reason is for this antenatal checkup, they need to travel minimum 10 kilometers to reach the nearest primary healthcare center and wait at least 5 hours to get 3-minute consulting from a doctor. Due to that, most of the mothers are not continuing their antenatal checkup on time. That leads to have high-risk pregnancy, and we could not be able to track those mothers. What we have done is we build a digital solution with the help of our innovative device, a wearable device which is given to the pregnant mother, and there is a medical device which is given to the health provider. If a mother is missing their antenatal checkup in the PHC, with our technology, we provide their antenatal checkup in their home. And during the antenatal checkup, we collect all their vital parameters, symptoms, and digitally we send this data to the doctor for feedback. And the health worker has an option to enable a teleconsulting with the doctor so that those mothers who are in antenatal checkup, they get the follow-up during this. So this is a special device we built for the PHC because sometimes we identify the high-risk mother and the hospital encourage them to go to the city hospital for a further follow-up checkup. But most of the mothers, they don't do this follow-up checkup. What we have done is we built this device which has an integrated video and medical device. In a live call, doctor from a city, they can talk to the pregnant mother who are in a high risk and they could able to diagnose. This is the application we have built. Allo Baby is the application for the mother, which provides more personalized care, and all this information captured in the system is shared to the husband. So the husband also involved into the pregnancy. And Allo Lab is for the health provider. With this, it's offline. It works on seamlessly on an offline system. With the face recognition, they can ensure whatever data are captured that is attached to that particular profile. And this is an application, AlloDoc, developed for the doctor. The doctor can sit anywhere, still they could able to provide consulting. So this application is designed such a way that it not only monitors during the pregnancy time, up to 1,000 days, it monitors both mother and children. This is the device we have built, a culturally designed wearable device. This continuously monitor the pregnant mother's sleep cycle, how much calories they are burning. Based on that, we design a personalized nutrition chart for them, and it also kept their health record in that. And this device is a special device. It designed such a way that the pregnant mother has to hold it for a few seconds to capture all the major vital information which required during the antenatal checkup, and captured data will be sent to the doctor through Bluetooth. This is how the data will be captured. Yeah. So most of this teleconsulting deployed in the PHC, sometimes the microphone don't work, camera don't work, and at the time of now teleconsulting, doctor don't get the in-person experience. So what we have done is we built this integrated solution. In a live call, you just hold the finger on top of the device, it capture all your vital parameters and send it to the doctor on the other side. This is how we are ensuring that pregnant mother is getting that live experience, in-person experience without going to the city hospital. We have successfully deployed the solution in the Western Ghat region, where a lot of tribal community we have covered. More than 36,000 antenatal checkup we provide as part of this program. Our main impact is because of this personalized nutrition program, all those things, we could able to increase the average baby weight almost 40%. And right now we are one of the recognized company to get access to National Health Mission of the country. And we are working with more than 70 plus PHC in Andhra Pradesh state to provide the antenatal checkup for mothers. Thank you so much.
Thank you so much for your presentation, Mr. Senthil Kumar. These innovations from India are so high tech. It fills us with hope, seeing that there are possible ways to really address maternal care and child care in India. So for the next segment of our program, I would like to, so our first reactor for today is Professor Obioma Nwaorgu. Professor Nwaorgu is part of the SIHI Hub Nigeria. She's a professor of the public health parasitology and epidemiology at the Nnamdi Azikiwe University, and she's also a Takemi Fellow of the Harvard School of Public Health, a Global Health Leadership Fellow, Rollback Malaria from WHO Geneva. He has worked with TDR in several research projects and is a member of the Research Strengthening Group RSG 2010. She's an executive director for a non-governmental organization in Nigeria called Global Health Awareness Research Foundation, GARF. We are very grateful for her presence, again, to share some of her insights and reactions regarding the social innovations of Cushy Baby and Save Mom. May we call on Professor Obioma Nwaorgu.
Hello, good afternoon, everybody. Unfortunately, I don't have a video to share because I didn't get this the innovations in time. But I'm pleased to listen to the innovations presented today by India. They're quite exciting. The Cushy Baby and the Savama Mom. Both of them are thrilling because they all refer to maternal and maternal issues in relation to death of both mothers and children, and how to change issues in India. And in both of them, they've utilized modern day technology to address the problem, which is part what SIHI is all about. And the applications they have used, especially for the Cushy Baby, is using the modern technologies like WhatsApp groups, home visits, as a means of tracking the patients. And what thrilled me is even in rural areas where they said the things are offline, they were able to use this technology to achieve the purpose and increase vaccination and thereby reduce maternal and child health. And when it comes to Savamom, which is another technology for reducing maternal and health of baby, artificial intelligence was used. And they were able to track the number of women who were not attending antenatal. And by so doing, they were able to, using what they call allo baby, they were able to increase the number of, or reduce the number of child mortality among women, among both women and babies, because they were able to ensure that women are, those women who were unable to attend the antenatals were tracked using this technology. And by so doing, managed not only to reduce maternal mortality and child deaths among this group, but also there was increase in the weight of babies. And with that, they saved a lot of lives. I wish to congratulate them for this contribution, and I hope this technology will be able to be disseminated to other countries, and much more to get to the last miles, the rural areas where this technology is needed badly, especially those places where you don't have electricity. I hope it will work in those places. Thank you for listening. And that's my little contribution. And I would say thank you and congratulations to SIHI India. Thank you.
Thank you very much, Professor Obioma Nwaorgu. Thank you for that wonderful feedback for both innovations in India, Kushi Baby and Save Mom. It's very nice that they use the modern day technologies, cell phones, the smartphones, in tracking the progression of child health and maternal health in India. Okay, so to proceed, next slide, please. SIHI Philippines Hub was established 2017. It is based in UP Manila and partners with the Department of Health and the Philippine Council for Health, Health Research and Development under the Department of Science and Technology. Last 2020, there was a call recognizing research on social innovations, the Helia Castillo Award for Research on Social Innovations in Health, where our next 3 presenters were all recognized. Clean water is still one of the main problems in the Philippines. Next slide, please. Where waterborne diseases such as gastroenteritis, typhoid fever are still rampant. The Alternative Indigenous Development Foundation found means to provide clean water to far-flung mountainous areas to supply the needs of the communities. So to learn more about this, may we call on the lead of AIDFI, Mr. Oki Idzenga, to share about the holistic water systems for pumping of water uphill.
Yeah, hello, good day. Hello, good day. I'm Oki Idzenga, CEO and co-founder of AIDFI, a Philippine social enterprise engaged in the manufacturing and installation of low-cost technologies for the poor. Our flagship technology is the AIDFI Ram Pump, a device that pumps water from lower to higher elevation without the use of fuel or electricity and without emitting greenhouse gases. We bring the Ram Pump water systems as an end-to-end solution. AIDFI was established in 1992 and has over the years built a complete infrastructure of workshop with precision machines, office, trucks, skilled technicians, community and management staff. We are at the moment with 30 full-time staff. AIDFI has an extensive track record with Ram Pump water systems built in 580 upland villages, benefiting some 290,000 people. It received numerous local and international awards for its holistic work. While main concentration on the Philippines, AIDFI Ram Pumps can be found in 15 countries and complete technology transfer has been carried out to Afghanistan, Nepal, Colombia, and Mexico. There are many waterless upland villages with water sources below, where mostly the women and children spend time on manual water fetching, which can be dangerous in raining season because of slippery trails. Often kids miss out classes because of water fetching. Some other villages, like elderly, pay for the water fetching since they can't do it themselves. Manual fetching limits volume to only 40 liters per household per day. Fetching causes neck and spinal problems. Look at the man on the picture on the left, carrying 40 kilograms over an elevation of 90 meters. Presence of skin diseases because of lack of bathing or washing. Presence of waterborne diseases since water sources are contaminated. Lack of sanitation, many households don't have a toilet. Laundry has to be done at sources below, and no opportunities for vegetable growing and animal raising around the house. Hereby a typical setup of a village water system where water is diverted from a source which we protect with an intake structure. This to the hydraulic ram pump. This pump operates and brings water through good quality HDPE pipes to a reservoir placed at the highest point in the village. From there, the water is distributed to public faucets or our newly developed water kiosk on the picture left on top. Those are placed near clusters of households. The villagers place a 1 peso coin equal to 2 cents in the mechanical coin acceptor, turn it, and 20 liters of water are then released. AIDFI is continuously looking for ways to innovate on technical, social, and organizational aspects in the end-to-end solution, which covers manufacturing, installation, social preparation, setup of water associations, training local technicians, and monitoring. No other ram pump manufacturer or installer has such a complete holistic approach. Technical innovations have been the unique ram pump model based on local materials and spare parts with an ordinary door hinge as the main part. Lately, recycling of plastic cups from soft drink bottles into sturdy gaskets has been added. AIDFI produces these plastic recycling machines also itself. The latest innovation is the mechanical water kiosk. A major outcome is the improved health and sanitation in the community. A major longer-term impact is the empowered women and communities. Water is for women very important in the many aspects of their daily life. No wonder that 53% of the officers of the water associations are women. In the empowered communities, we see that our idea of the ram pump triggering further development is really happening. For systems and water associations to operate sustainable, it is key to create sense of ownership over the system and organization. For that reason, the beneficiaries are as much as possible involved in all aspects of the installation, from orientation, attending meetings and trainings, hauling to actual construction. That, as earlier said, women play an important role in the water associations. They understand and feel the need for increased volume of water to make their lives easier, and definitely do not want to go back to the old way of water fetching and therefore lack of water. The water kiosks are a key in making the technical and organizational operation of the system sustainable. The amounts collected from the kiosk remain in the community and are also intended for other livelihood activities. AIDFI has the capacity to implement 25 complete village water systems per year. In the past, we did even more systems per year, but quality and working atmosphere were affected by running after higher numbers. The focus now is on building quality and sustainable systems. Besides producing ram pumps and water kiosks for its own systems, AIDFI can produce for other clients. AIDFI is open to transfer its ram pump model to other countries. Then there is a need to diversify the funding of AIDFI through sources like CSR programs, philanthropy, water or carbon offset programs, governments or international agency programs, or even crowdfunding. I hope that this very short presentation gives an idea that ramp pump water systems are a perfect technology to reach the unreached, of which many are living in the uplands. Bringing free-flowing water in their communities changes lives. For more information, visit our website, is here on the right down. And thank you for the invitation and your attention.
Thank you very much, Mr. Idzenga, for sharing with us your innovation, the innovation of AIDFI, especially in delivering water supply in the uphill mountainous areas in the Philippines and even in other countries. All right, so to proceed for the innovations in the Philippines. Mental health in the Philippines remains to be a taboo despite the availability of information found in different media. This gap in accessing and availing mental health programs is addressed by PsychServe. Let me call on Dr. Bautista, Dr. Divine Salvador, and the team to share with us this solution that they have for mental health.
Thank you very much, ma'am. Do I have permission to share my screen now? Let me see.
Yes.
Okay.
We'll check. Yeah.
Yes, I can. All right. So thank you for giving us the opportunity to share with you today what we do and who we are at the University of the Philippines, Diliman Psychosocial Services, or UPD PsychServe for short. We are a special project under the Office of the Chancellor of the University of the Philippines in Diliman, and our mandate since our creation in October 2017 is very simple. It's to provide mental health and psychosocial support services to the UP community, to the UPD community, in response to what we had observed, not just within the university, but across national consultations among the universities, to be a rise or an increase in reported distress by our students. So on paper, our mandate was pretty simple, but what has animated our work and what has guided us for the past 4 years is really a vision. And that vision is that universities can be transformed and can become caring and compassionate communities that nurture ginhawa or total well-being for its constituents, that universities aren't simply concerned with high performance and high achievement, but that we would take it upon ourselves to bear the responsibility of supporting our constituents. And so what we've been working towards is not just mental health, but what we call ginhawa. Ginhawa is a Filipino word. It's an indigenous concept that refers to the sense of total well-being that is experienced by a whole person. It is experienced fully and in a whole-bodied way. And we are deliberate in using this indigenous concept because it orients our work to dimensions of being that would otherwise be ignored by more mechanistic frameworks. PsychServe is composed of psychosocial support specialists. Most of us are trained in clinical and counseling psychology, and we provide mental health and psychosocial support to those in the UP Diliman community who grapple with complex problems of living in mental health conditions. However, beyond being so-called experts, we also see ourselves as partners. So we view ourselves as a community center. We are mindful of our place in the bigger university community. We build and nurture partnerships across our university community. We have partnered with administration, with leadership, but down to campus security, campus maintenance. So it's across the board. We've partnered with academic programs as well. And our clientele is equally diverse, even within UP Diliman. On the one hand, we serve people who have vulnerabilities and have diagnosable conditions, but at the same time, we also offer services to those who are well and who want to continue nurturing and cultivating that sense of wholeness and thriving in the university. We serve people who clearly need our support and services, but at the same time, we also work with service providers and caregivers who want to be more effective in providing care to their colleagues as well as to their students. So the COVID-19 pandemic paradoxically gave us this gift because originally our mandate was confined to the university. But because of the pandemic, we had to pivot very quickly towards telepsychotherapy or telehealth mode. So we were the first programs to offer pro bono telecounseling, telepsych service to the Philippine public at the start of the pandemic. And that's where funds have allowed us. That's what we've continued to do. We've also been blessed with opportunities to extend our partnership endeavors outside of the UP Diliman community to include our partner units across the University of Philippines system, as well as other agencies and organizations outside of UP and within the country. So what we're pretty proud of, what we do is that we are able to show people that the picture, we are able to change the picture in people's mind of what a mental health and well-being clinic or center is. Typically, people think of a mental health clinic as one where you go if you need immediate relief from your mental health symptoms and problems, and you get fairly specialized services. And of course, we do have our specialized services, but it is only one part of a broader spectrum of services and programs that we offer, which are guided by our 6-component Ginhawa framework or Ginhawa model, designed to, on one hand, address risks and vulnerabilities, but on the other hand, to nurture resilience and growth. So let me just walk you briefly through the services that we have. Of course, first is our direct services like psychotherapy and crisis counseling. The second component is the learning programs. We have a flagship Lifeline series of workshops designed to help faculty and staff become much more effective providers of care, of compassionate care to students and colleagues who could be hurting. And so it's something as simple as how do you make a referral, an important referral? How do you engage in basic crisis work? We also have personal growth workshops. As I've mentioned earlier, we do serve people who just want to cultivate that sense of flourishing and thriving and are not necessarily struggling with mental health conditions. So we do have these learning opportunities for them as well. The third component in our approach is consultation. And our flagship consultation program is called Creating a Total Inclusive Environment for UP Diliman. And this is a program where we work with faculty, staff, and students in providing reasonable accommodations for students with psychosocial disabilities. Just last week, we had a research forum to disseminate the findings from our comprehensive multi-sectoral study on accommodations, experiences, and needs of the university community. We are also engaged and actively involved in developing the kinds of systems and processes that will ensure sustainable, compassionate care. So one of our early achievements has been to develop the principles, policies, and guidelines on MHPSS for UP Diliman. And we are currently partnering with service units across the university to create a mental health network of coordinating cooperative and autonomous MHPSS units in the university. We are also involved in research, so we scrutinize our own suite of services. But at the same time, we offer the research service to our, for example, academic program units who want actual empirical data on the mental health needs of their constituents so that this could become direct input to their planning. And last in our 6-component Ginhawa framework is advocacy. We are keenly aware of our role in the public discourses in mental health and well-being. And so we have committed to have this regular suite of activities and opportunities for people to get together and have these important conversations. And we partner with not just professionals, but for example, we partnered with artists to come up with these art exhibits on important messages for ginhawa and mental health. But we've also had very simple events, such as having simple conversations between people to harness the healing power of having a conversation without any agenda. And so we just wish to continue all these activities. And we're hoping that we could have an opportunity to partner with another university or another school, so we could see whether our 6-component ginhawa framework could be contextualized to fit the needs of another higher education institution. So for us, ultimately the innovation we offer is really that view that mental health and well-being is a collective effort, and that people and individuals are not simply passive recipients of service, but that we have the shared agency and responsibility to create the learning environments that promote well-being alongside performance and achievement. Thank you very much.
Thank you very much, Dr. Divine Salvador. Thank you for sharing with us your innovation in mental health. Mental health isn't a simple problem. It really relies on the community, and the 6 components would really help, especially the students of UP Diliman and even other clients from other universities that you have also mentioned earlier within the community. It plays a big role and an impact on these children's lives, as it would of course help them in their growth and when they mature as individuals. All right. So to proceed with our next presenter. Tuberculosis remains to be one of the top causes of mortality in the Philippines and in terms of infectious diseases, amidst the call to end TB by the year 2030. This is where innovations for community health enters the picture and offers a solution contributing to this call. Let us listen to Dr. Jason Alacapa and his team to learn more about it. Hi, Jason.
Hi, Carissa. Let me share my screen. There you go. Can you confirm that you could see my screen?
Yes, easy.
All right, thank you. It's an honor to be introduced by Carissa. Carissa has been part of this innovation. So yeah, I am Dr. Jason Alacapa from the Innovations for Community Health, and I am tasked to present KALINGA Health, a novel hub-and-spoke private provider intermediary model of TB care in the Philippines. So this is brought to you by Innovations for Community Health, an NGO which promises a value proposition of creating sustainable community health. Let me start by sharing the story of Mr. Juan. Mr. Juan is a 58-year-old construction worker in an eastern city in Metro Manila. He is a diagnosed case of pulmonary tuberculosis. He knows that he can get the treatment for free from Public Health Center, DOTS. For those who are not familiar, DOTS is the mechanism in which TB patients are given medications daily for 6 months. However, because he fears that the care is not of good quality, and he fears that the other people would easily know that he is a diagnosed case of TB, as it will easily get spread in the community, he opted to get for private care. In private care, he needed to spend for his treatment. What he did not know is that he needed to buy medications daily for 6 months. Unfortunately, because of his financial incapacity, he dropped out from his treatment. Because he dropped out from treatment, he developed a drug-resistant tuberculosis. And drug-resistant tuberculosis, unfortunately, led to his untimely death. The story of Mr. Juan is only one of those suffering here in the Philippines. In the Philippines, according to a baseline survey in 2016, 94% of private sector cases are not reported to the Department of Health National TB Program. This is ironic to think, especially that half of the health services are provided in the private sector in the Philippines. Another important thing to note is that 95% of TB cases in the private sector are clinically diagnosed. This is again during the baseline year mentioned earlier. This suggests a poor quality of TB care. Ideally, a TB patient should be diagnosed using a test called GeneXpert, an RT-PCR-based technique very similar to what is being used to diagnose COVID-19. Mang Juan is only one of the many missing cases of tuberculosis here in the Philippines. In this study, in this survey, it was estimated to be 33. This is estimated to be 670,000 TB patients annually. Now we zero into this specific clientele. We zero into their specific pain points. Mang Juan is a typical TB could be a typical TB patient in the community. He has concerns on the public health system. He perceives better quality of care with private doctors. He perceives lesser stigma with private medical care, and he was unable to finish treatment due to out-of-pocket costs. On the other end, we also have the other target clientele, the private physicians or providers. They want to maintain more patients under their care. They may not be comfortable to refer out all their TB patients because this is their source of livelihood. They may lack access to affordable but quality TB diagnostics and treatment because the Philippines remains to be one of the remaining countries which does not provide free medications for private sector patients to treat tuberculosis. Another issue is the difficulty in the compliance in terms of the reporting to the government system. And of course, there's also challenge in terms of maintaining 6 months of treatment for tuberculosis. So what is our solution? Our solution is KALINGA Health. KALINGA Health is a purposefully built infrastructure, both a physical and a soft infrastructure. It is an intermediary hub and spoke social enterprise model. So let me break down those concepts. It's an intermediary because it acts in between the national government, represented here by the Department of Health National TB Program. And on the right-hand side, we have a network of engaged private provider. Since we are in the middle, we allow transfer of resources, expertise, and standards assurance from the government to the network of private providers. We are a hub and spoke because the buildings, the infrastructure I have shown earlier, serves as the core hub connected to a network of private providers in cities where we are currently in. This slide just shows the menu of our services from consultation to compliance to mandatory reporting to the Department of Health. We brought teledots innovation, 6 months of case holding and follow-up, free treatment and diagnostics. We have GeneXpert, we have X-ray equipped with artificial intelligence. During the pandemic, similar to the experience of PsychServe, we became creative to reach our patients, and we launched KALINGA Health Teledots, the new normal for TB care. We may be familiar with telemedicine delivery of different healthcare services, but this one is not just limited to consultation. It encompasses end-to-end TB care. It includes collection of sputum specimens so that we can test it. It also includes provision of free medications via delivery mode right at the comfort of your own houses. What is our impact today? Since operating back in May 2019, we have served more than 3,600 supposedly missing patients. We have given free treatment to almost 1,000 patients. We have led to a 90% reduction of the price of GeneXpert. Remember, GeneXpert is the primary diagnosis for tuberculosis. From $100, we brought it down to less than $10 per testing. And if you're indigent, we actually waive it for these patients. KALINGA Health has saved a total of estimated $300,000 for these patients. Now, another bonus, we're also able to contribute in terms of diagnosing the drug-resistant cases of tuberculosis. At our peak performance in a city where we started our work, we contributed 60% of the cases in that city. This is very important because this empirical data suggests and confirms somehow our assumption that a lot of the missing cases in the private sector could be a source of these drug-resistant cases. What happened during COVID-19? Yes, TB cases were down as with the other diseases. However, our facilities, KALINGA Health, remain to be a top performing health center or basic management unit in the city where we started our work. So what does our partner physicians say? So in a study led by Professor Castillo Carandang, acceptability study, we found out that our partner provider says that our intervention is accessible in terms of geography, in terms of the time, in terms of the financial accessibility. In terms of service capacity, it was also comprehensive before because we are able to provide end-to-end care. In terms of patient centricity, we receive a lot of positive feedback from the patients from the clinic. This feedback come from the actual patients served within the clinic. And our partner providers have a habit of asking the patients who go to our facility regarding the quality of care that they receive. And interestingly, we attract a specific cadre of partner providers. Most active referring doctors are the ones who deem the profit loss as negligible because they believe that the intervention is for the greater good in the long run of ending TB in the Philippines. So what's next for us? We have established our hubs into key cities in Metro Manila. We have expanded the reach of our services through teledots in 3 more cities in Metro Manila. So we hope to expand these services more in the other 10 more cities in Metro Manila. We're not only focusing on tuberculosis, we have expanded our services to other diseases as well. We have our own laboratory. We hope to scale up soon the operations of this laboratory so that we can serve more patients, not just tuberculosis patients, but also other Filipino patients needing our care, all in the hope of treating those TB patients who are in need. So in the end, we want to ask, do you want to save lives and help end TB in the Philippines and beyond? I hope the answer is yes. Continue supporting innovations for community health, KALINGA Health. With that, I am Jason from Innovations for Community Health. Thank you very much.
Thank you very much, Jason, for your presentation. It's nice learning that, of course, we really need the collaboration from the private physicians so that we will be able to, of course, to the private public service, especially for patients needing TB care. It has a great impact of course, in the whole Philippine society, as it is able to really capture a lot of TB patients who are usually being diagnosed by the specialized physicians. All right, thank you very much. Okay, so to proceed, our second reactor for today is Dr. Jackeline Alger. Dr. Alger is a clinician, a researcher, and a teacher. She has been on the field of conducting research studies on infectious diseases such as malaria, Zika, and COVID-19. She's a member of the PAHO, Pan American Health Organization, the WHO Advisory Committee on Health Research, and TDR. She has also been awarded as the Physician of the Year in Honduras for the year 2019. Hence, we're really grateful that she's able to be with us today to share some of her insights and reactions regarding the social innovations from the Philippine Hub. So again, may I call on Dr. Jackeline Alger.
Thank you, Carissa. Thank you very much. Well, I would like to start congratulating these innovators and their teams. The solutions that they had presented us and the pitch that they developed to present the information is very effective. I can appreciate that these 3 innovations are presenting solutions to public health problems and that are common in Philippines. And I can appreciate that their solutions came out in specific places, but these are problems that are common probably across Philippines as well as across the world. I can say that they are common also in Honduras, Central America. So these are common problems, but these are very specific and innovative solutions to approach these problems. I can also appreciate that the innovations came out from different contexts. We see the AIDFI social enterprise. We can see a university, the University of Philippines, and also an NGO. So these three innovations are showing us the diversity of approaches that can be implemented to solve common problems. But these problems needs to be contextualized, and that's what they did. Also, I appreciate that in the context of the COVID pandemic, these solutions are very are tackling prioritized problems within the pandemic, because one is tackling water access, safe water access, other is mental health, and the other is an infectious diseases of poverty as tuberculosis. And all of these problems are also common across the world. Across the world within the pandemic, we had these problems about access to safe water. Mental health was has been and still is an important issue, and how these infectious diseases of poverty like tuberculosis and other infectious diseases, as well as other chronic diseases, have also been affected within the pandemic. In regard to, those are like general comments, but in regard to some particular comment to each one, well, with the water system, the holistic water system for pumping, I can say that also, well, this geographical issue of mountainous terrain precluding the communities to have access to water and to have to invest so much time and resources to go to the water are common also in other places worldwide. So this innovation using this mechanic hydraulic water ram is provided this solution for these communities, but as the innovator said, they already are tracking some result. They already have a tracking system to understand their results, their impact, and also they are escalating, they are growing and escalating their solution to other countries. Anyhow, I can see how this solution could benefit from the interaction of other actors, such as agriculture, education, even maybe science and technology, and even tourism, because this solution also had an impact in productivity within these communities by giving them this essential resource, water, but also freeing time to devote to other activities. So this is also an example of how we can contribute to the Sustainable Development Goal 3, which is for health and well-being, in a very effective way. In regard to the Diliman psychosocial service, well, I can say that, well, they offer this for students, faculty, and staff. And they mentioned that they interchange already across universities. But I can see how this approach could also be benefited by including other actors where a group of peoples are, and can be benefited by mental health care, such as group of peoples that are within working within factories or in the industry. Also, not only university level, but also elementary school and secondary school. So all these settings where group of people can be benefited by this mental care, innovative mental care. They already explained within their different phases and aspects that they have included research. But as I understood, is supporting research on the topic, but they also could benefit by researching themselves, partnering with someone to research themselves and trying to understand better the impact, the metrics of the impact they have made. And in regard to the KALINGA health, I would like to say that also is common in other countries. We have seen how the care, the tuberculosis standard care in the public sector is neglected because of different barriers. Many different barriers, and we learn some of them by Jason's presentations. So the innovative way they are approaching to contribute to solve that problem is very interesting. They are also contributing directly to this Sustainable Development Goal 3, because all these infectious diseases of poverty are highlighted, but tuberculosis is mainly highlighted because of its prevalence and the effect and the fact that it can be prevented and it can be cured also. Going back to the Diliman psychosocial service, I would like to say that they contribute to the Sustainable Development Goal 3 also. And the holistic water system, in addition to contribute to SDG 3, is also contributing to the water system, so to the Sustainable Development Goal 6. The KALINGA Health Project solution also describes some research. They did some research to understand the acceptability. So they are in that strategy of tracking their impact, how to assess their performance, collecting these metrics to assess the performance and the impact of their solution, which is good because that can contribute learning more, understanding more. They understand very well their solution, but once the solution is within the context, there are many other dynamics and factors, actors, and dimensions that interact, that is very dynamic and needs to be constantly understood, to plan, to act, to project their, to visualize and to plan future actions. So I would like to conclude saying that all of them are doing somehow, which is very important. All of them are doing somehow of research and tracking, registering their metrics. But I know that with the support of the Philippine Hub and the SIHI Secretariat, they could do a more systematic evaluation for their own benefit and also the benefit of the populations and communities that they serve. Congratulations again. Thank you.
Thank you very much, Dr. Jackeline. Thank you so much. So we'd like to thank our innovators from both the SIHI hub in India and in the Philippines. Again, thank you to our reactors, Professor Obioma Nwaorgu and Dr. Jackeline Alger. So this ends the first part of our program. However, if you would like to raise some questions to our innovators, you can send it directly to their email addresses, which they gave after their presentation. Okay, so to proceed with our program, the second part of our session is entitled Strengthening and Sustaining Social Innovations in Health. Here we get to listen to the experts on the field and the different approaches utilized in social innovation in health. Once again, please feel free to type your questions in the chat box and comment section for those watching us in YouTube. Okay, next slide, please. So our first speaker is the manager for SESH Global. He received his PhD in epidemiology from the USC-LA Fielding School of Public Health and his MD and MS in epidemiology and biostatistics from Nanjing Medical University in China. His work focuses on STI control and prevention strategies in China. He's a research assistant professor in UNC Chapel Hill School of Medicine and assistant director of the UNC Project China at the UNC Chapel Hill. So let us all welcome Dr. Wei Ming Tang as he talks about identifying social innovation through crowdsourcing open calls, methods, and processes. Hi, Dr. Tang. You're muted.
Oh, sorry. Yes, sorry. Thank you for the introduction. It's our great pleasure to share our work regarding what we have done in using social innovation strategies to improve health in China as well in other countries. Today, I want to present a specific project we have done recently, which is still ongoing. The idea of the studies is to actually use social innovation strategies, crowdsourcing to identify, use social innovation in different countries, globally. The aim of this study is simple: is actually to implement a global use social innovation call to identify interventions that can address infectious disease and poverty issues encountered by youth. We also have a subtitle called "Imagining the World Anew," because in this open call, we actually ask the youth people to think about their future, what the future will be, and how the impact the COVID-19 will impact their future, something like that. So since we actually conduct this this open call step by steps. First of all, we actually conduct these steps as the first step of the open call in 2 countries, which is in Philippines and Malaysia. And at this stage, we are already moving to the second stage, which is have a global open call, which is we have already finished our steering committee organization and organizing. So I would like to present the current results regarding the first stage. For the first stage, we worked with Philippines SIHI Philippine Hub and Impact Hub Malaysia in conduct this 2 parallel crowdsourcing contests in the 2 countries with the support of WIPRO and also other partners. The idea, as I mentioned before, we want to let youth to think about their future and how the COVID-19 will impact their future, and how to address the challenges they might in the future. So in this call, we actually ask them to think, what the future will be and how can they address the barriers. So we actually work with, as I mentioned before, we work with 2 main partners in 2 countries, which is SIHI Philippine Hub and Impact in Malaysia. We first organized the steering committee with the local partners And then we started promote the crowdsourcing, the open call in the countries through social media and the press media, for example, through the Facebook or Twitter. And we also organize some like in-person activities in the country. There are these two countries are all actually finished all the first part of the call. The call for submissions were basically based on the youth innovation, youth messaging, and the future thinking and the strategic planning for the future. For the judging in each country, we select the top 3 finalists from all the 3 thematic tracks by steering committee members. Each submission was judged by 3 independent judges. And later on, we have a national showcase, which means we have announcement of the winners of the finalists during the national showcase, and also have the finalists present ideas or stories. And we have also have like keynote sessions to have them to have the other peer members to give them like feedbacks. In addition to the open call, we also organized 2 digital designer songs in the 2 countries separately. While designer song sessions is this like a Zoom call for like a 1-day workshop or a discussion or co-creation workshop. Actually, during the designer song, we have the groups to present the ideas, have the mentor team to give feedback to their ideas, and then have them to further work on the ideas for the improving. So in this way, we also provide the mentorship to them while help them like they can put some of the ideas into implementation later on. Well, this is some pictures from our steering committee meeting. This is the COVID-19 period. All this were actually digital. Thanks for all the organizers who help us to organize this, and thanks all the steering committee members who contributed. At the end of the day, we actually have lots of submissions in 2 countries. For example, in Philippines, we have 113 submissions, and in Malaysia, we have 41 submissions. This typically covered all the 3 tracks we wanted, which include use a voice to create the post-COVID-19 world. Actually, the majority of the participants actually submit their interest to this part, maybe because of like COVID-19 really changed a lot of things, and they need to think about what they can do after the COVID-19. We also have some submissions related to youth-led COVID-19 related innovations and youth-led social innovation strategies beyond COVID-19. For example, future thinking's part. Yeah. And after that, we, as mentioned before, have a separate designer songs. We have 2 designer songs. A total for the Philippine designer song, we have total 28 finalists and the grand winners who we invited to attend a 1-day online civic hackathon conducted via Zoom on January of this year, which is pretty well. And we identified a very great idea called the boring book. This idea was actually very interesting, and the WHO Pro team like this idea very much, and we are at the stage to further promote the idea. In Malaysia, a total of 15 finalists were invited to attend a 9 designer song on June of this year. And we also have a bunch of steering committee members or mentors to help them to further polish their idea. We are at the stage of summarizing this kind of co-creation activities, this kind of course. We are submitting this to the BMJ Special Issue Collection on Social Innovation. That is at the stage of call for submissions. The right side is the poster for the call for submission. If you are interested in this open call, please also submit your submissions to this special collection on innovation. So at the next stage, we'll have to have a global open call to further conduct this more globally. Actually, the The open call in Philippines and Malaysia is more like a phase one of the youth innovation, and the phase two will be the global one. So in the phase two, we want to engage more people to contribute. We wanted to have hear the youth voice more globally to solve the problems globally in different contexts. The aim of this call is actually to reach at least 500 global submissions from youth and to recognize exception projects at the local and the national level, except how they address the impact of COVID-19, and to support final research and implementation projects at the local level. Yeah, this is typically our timeline. We have started to draft the submission proposal and we are at the stage of the recruit the steering committees. And if you are interested to join the steering committee, please also let us know. Later on, we'll have the steering committee meeting after the new year and start to move this forward. Yeah, that's it. Thank you very much. This is typically what we have done for the social innovation for youth. Thank you.
Thank you very much, Dr. Tang, for sharing with us the utilization of crowdsourcing as a tool for identification of social innovations. Your experience with this is very fruitful. So to proceed with our next speaker, he is the Vice Dean for Research and Development, Faculty of Medicine, Public Health, Nursing, the Universitas Gadjah Mada in Indonesia. He's a medical doctor and obtained his master's degree in international health from Humboldt University in Berlin, and his doctorate degree in medical science at the Ghent University. He is currently leading the Southeast Asia Regional Training Center for Health Research, supported by the TDR. His research interests are in the fields of global health, implementation science, disease control, health policy, and health program management. So without further ado, we would like to welcome Dr. Yodi Mahendrata to talk about co-creating social innovations through implementation research. Hi, Dr. Yodi.
Hello. Let me just share my screen first. Is my screen visible?
Yes, you can see it.
Yes.
Okay. Okay, thank you very much. So I'm going to talk a bit about advancing social innovation through implementation research. But just to begin with as a background in general, it was very encouraging to see that many of the social innovation which was presented in the previous hour actually already went into research to a certain extent. Now, I just want to highlight the importance of research for social innovations. So as we know, the development and introduction of any social innovations in any case will inevitably require iteration to review, evaluate, and tailor its activities to fit with any given community. And for that, it will benefit from research. And also, limited understanding of the success or failure components of any social innovations would limit the ability to learn from its implementation or to replicate or scale it up to other communities and populations. So again, that would benefit from research. So the point here is that research which is a collaboration between health researcher and policymakers, social innovators, and communities have the potential to address these challenges altogether. Now, why IR? IR by nature seeks to understand what, why, and how intervention or innovations work in any given context. And also, if you look at it with its origins in several different fields, IR has inherently a mixed method approach and also being very flexible to account and adapt to changes in the innovations which are being implemented. And third point, the focus of IR on users, whether it's communities, policymakers, is also an added value. It's a strength which moves IR as a research beyond a focus on the productions of knowledge. Now, at its heart, we see IR is no systematic approach to optimize innovations or interventions. So it's actually moving innovations or interventions within a pathway from a suboptimal stage to a much more optimal stage. So it's like a wheel which goes forward. Now, how does it do that? I mean, it optimizes the innovations by basically systematically identifying implementation bottleneck, also by identifying optimal approaches and promote uptake of innovations systematically. Yeah. And it does that also by focusing sharply on the implementation outcomes. And there are many implementation outcomes, which are usually the focus of implementation research, but these are just some which are most commonly focused on most IR projects. So for example, the acceptability of certain innovations, the feasibility, the appropriateness, fidelity of the implementation of the innovations, the adoption, the coverage of the innovation, the cost of implementing the innovation, or the sustainability of the innovations. There are more, but again, these are just to give you an idea of what are the most commonly assessed implementation outcomes within a given IR project. Now, what's powering IR is its characteristic. So first of all, it is systematic, meaning it is basically following the scientific method as a research method, but also because it's multidisciplinary, because we are dealing with implementation issues, which usually cannot be addressed by one particular discipline. It requires several disciplines to be able to address implementations. And by nature, it's complex because any implementation of innovations is complex. So also the study is complex, and it's contextual because we realize that even the same innovation being implemented in a different context might lead to different outcomes because the context really matters. So the context here is something which we really take consideration into account. And also to realize that IR is always in a real world situations. We never try to control the situation where the IR is taking place. We take it as it is, as a routine setting, as an operational setting. And also, what is at the heart of IR is that it is demand driven, meaning it's not driven by academics, it's not driven by the supplier of knowledge, but it's driven by the people in the field, by the implementers. So it's the initiative should come from the field. And also the research questions are developed with the stakeholders, the implementers. So it's not developed by people in campuses behind the desk, but it has to be something which comes out bottom up from the field. And also it has this co-creation component, which is also very much similar to social innovations. The co-creation here is that the implementers is a very important part of the research process. Now, so what are the potential roles of IR for social innovations? There are, of course, many. These are just also a few to give you an idea. So if we look at the implementation outcome, so what IR can do is, for example, to enhance the acceptability of certain social innovations. It could perhaps increase the coverage of certain innovations, could also improve efficiency by looking at the cost of implementation and see where you could actually minimize cost. It also could increase the sustainability of social innovation by looking at the capacity for sustainability and how to improve them. And last but not least, it could also help in terms of replicating certain social innovations to other settings. I mean, in the past hours, we see so many social innovations, which it would be nice to replicate to other settings, and IR could help on that, for instance. And these are just some examples of implementation research which has been completed by our postgraduate students, which are supported by TDR, not necessarily social innovations, but different kinds of innovations. So for example, here, one of our students from Vietnam, he was looking at the barriers to engage communities in a dengue vector control program. You can have a look at it later if you want to see in detail how it looks like as an IR. This one is our students from the Philippines, and he was looking into the acceptability and feasibility of delegating HIV counseling and testing for TB to community health workers. This one is from our students in Nepal, and he was looking into the appropriateness, the acceptability, and effectiveness of mobile SMS to improve dengue prevention practices in the community. So to end with just a few closing notes, basically IR promotes partnership between social innovators, communities, policymakers, and researchers. And this can leverage the experience and expertise of each to gain and advance vital knowledge. IR also requires that community and broader stakeholder engagement approaches are treated as being on par. So it is as important as the research method. Okay? So it's not something which is secondary, but it's as important as the research method. The engagement of the stakeholder is as important as the research method. And that by adopting IR, by valuing each stakeholder as a holder of expertise as well as recipient of new information, and also emphasizing co-creation of knowledge, we are actually increasing the chance of better health outcome. Thank you very much.
Thank you very much, Dr. Yodi, for giving us a bird's eye view regarding the implementation research and its impact on the society as a model for co-creating solutions with the community. Thank you very much. So for our third speaker, she is an assistant professor in the Department of Health Behavior at the Gilling School of Public Health. She also serves as the Health Behavior MPH Concentration Lead. She has a decade of experience as a teacher, public health practitioner, and researcher, and earned her MPH and PhD degrees in this department. Dr. Chen's research interests are in the intersection of adolescent health, technology, and design thinking. Let us all welcome Dr. Liz Chen as she shares with us how to embed social innovation in research and research in social innovation, the SI monitoring and evaluation framework and checklist.
Thanks so much, Carissa. Okay, so we are happy to end today's presentation with two specific tools for folks to take into their future research and practice. And so we know that it's important to understand what works and what does not work, especially in under-resourced settings where time, money, and human capital are limited. And right now, social innovations for health aren't developed or reported consistently, so it's really hard to cross-share and learn. And up until now, there has been no specific tool or framework to measure and evaluate social innovations for health or to report them. And so with Dr. Wei-Ming Tang, who presented earlier, and others, we followed a process to develop both a framework for monitoring and evaluation and research checklist through many steps. And so we have published a paper that describes this process in detail, but in essence, we opened a crowdsourcing call for ideas across the globe. We conducted a scoping review. We hosted several months of multi-sectoral discussions and then used an adapted Delphi process to finalize both our framework and our checklist. And so for our monitoring and evaluation framework, the purpose was to offer a tool for social innovations for health, to help democratize research and engage more stakeholders to work in partnership with researchers, and to really help us build a way to understand effectiveness and the potential for sustainability for all these great social innovations for health, including the ones we've seen today. And so while we only have 10 minutes, we won't be able to go in depth, but would like to at least show the overall monitoring and evaluation framework. And some of the key pieces include, first, the circle in green all around the outside highlights that end user co-creation and feedback are central to all stages of this evaluation framework. Second, we have 4 pillars of social innovation, including social benefit, effectiveness, inclusivity, and financial sustainability. So those were central themes throughout that we wanted to make sure that folks were thinking about at all stages. And then we have 7 specific phases that we recommend folks go through, and would like to also highlight that number 4, making a case for evidence and data, is actually earlier in this framework than in others. And so we really prioritize building that case and figuring out how to monitor and evaluate early, even before delivering and implementing. And then next, the Social Innovation for Health Research Checklist, or SIFR, is now open access and includes 17 items and is adapted from the tidier checklist, so the template for intervention description and replication. We have developed this checklist for social innovations in health with low and middle income countries in mind, and it's intended for researchers, innovators, academics, and others interested in social innovation. So we hope that this leads to more reporting, a greater transparency overall, and greater comparability and replicability of social innovations in health across low and middle income countries. And so this particular resource would be great for folks who have been involved in projects like the ones we heard from today and are getting ready to either present or publish papers on these projects and would like a way to make sure that they are complete in their reporting so that others can learn from the work that they've done. And so here are the 17 items. And in our publication, we not only offer a prettier version of the checklist for you to print and use, but also descriptions of each of these different components, and then a couple examples. And so some of these are pretty straightforward: brief name, problem, rationale. We'll draw your attention to 14 and 15 and how we've broken apart health impact and social impact as two separate entities, and then always ending with the strengths and limitations. And so want to thank all of those who supported our work up until now. And we have many acknowledgements for those who are involved. And want to also share the website link for our interactive website for the framework that is clickable and colorful, as well as the citation for the open access journal that shows the research checklist in its full form. And the QR code links you to that as well. Thank you.
Thank you very much, Dr. Liz Chen, for sharing with us the SI monitoring and evaluation framework and checklist. This will be very helpful to our innovators and our TDR grantees, especially if since they will be publishing papers on their current solutions. All right. So for the next part of our program, this is actually an open forum. If any of our participants would like to ask questions to our three speakers for today, Dr. Yodi, Dr. Liz Chen, and Dr. Tang, kindly type your questions in the chat box. Earlier, Mr. Joe Tucker also shared with us the websites where the Social Innovation M&E framework is found, the website version, and the Social Innovation Research Checklist. So you can click the links found in the chat box, and it will direct you. It will lead you to the website. So if you also have questions for our innovators, it would since they are also here with us, you can just type them in the chat box. I will read them out aloud.
Okay. Carissa?
Yes.
This is my question to Yodi. Yodi?
Yes, Noel.
Yeah. I just want to ask, like for example, I know there's an ongoing training on IR, and the training center for Asia region is with Kajamada. What are the schedules for that one, so that for people who are interested, like from the hubs members here, who can probably take the course?
Okay. So actually, for the Asian region, there are two. So we are at the WHO Southeast Asia region, and for the Philippines, which is under the Western Pacific region, actually, it's actually based in Malaysia. So there is a regional training center in Kuala Lumpur, which are organizing trainings for the West Pacific region. We are more than happy also to welcome you and others to our region. It's just that our own budget by TDR, Pascal is here, he can clarify. We can only use it for the Southeast Asia region. But having said that, most of the trainings are at the moment online anyhow, so there is not much cost involved in terms of accepting additional participants. So we are okay to welcome additional participants. The issue is only if we have to finance people to come into Indonesia to undertake training. So in terms of the IR at the moment, I mean, we are finishing the courses because we're approaching the end of the year. So we do not have any course. We already completed our IR courses a couple of months ago. So just to also to give you an idea of what kind of trainings we have. So the first training we have is on the implementation research toolkit, which is available online. You can just Google it and you can find the TDR implementation research toolkit. And that one basically walks you to proposal development. And so the output of that is to develop IR proposal. So it's very practical. It's step-by-step guiding you to develop IR proposal. The other one that we are doing with Pascal and Noah, who is also here, is the IR MOOC, Massive Open Online Course. That one is open to the whole Asian region, West Pacific and Southeast Asia. And that takes about a month to follow. And what's interesting about that one is that that one is integrated with a small grant program. So the participants are asked to develop a draft letter of expression, and then based on that, we will select the best 10, and each the best 10 will get a small grant to actually carry out the IR project they propose. So that's the second type of IR training that we offer. The third one is the postgraduate. So for the postgraduate, it's a 2-year program. It has emphasis on IR, and that one is open also to the West Pacific region. So we have students from the Philippines also for that one. And for that one, we are probably going to have the call around March next year. So we've already accepted the first the batch in September for this year, and usually we will start again in next September, and we will announce the call around March. So those are the 3 trainings we have on IR. So for the MOOC and the postgraduate, it's open to both regions because it's not offered by our colleagues in Malaysia. But for the workshop, for the trainings, it's offered through our colleagues in Malaysia in collaboration with us. So that's it, Noah.
Thank you, Yodi.
Welcome.
Thank you very much, Dr. Yodi. Thank you also, Dr. Noel, for the question. I think a lot of our participants are very interested in learning more about implementation research from your presentation today, Dr. Yodi. I would like to read out one question raised in the chat box. This is from Joe Tucker. For Dr. Liz Chen, do people need to have a master's degree to use the tool for the SI monitoring framework, and what research experience is needed? I believe you've answered this in the chat box, but also for our participants in YouTube, maybe you can answer this live for us, Dr. Chen.
Yeah, thanks, Carissa. So nope, no specific training or degrees are needed to use these tools. We've tried to be really intentional in putting them together, that we want them to be used and therefore have no prerequisites or requirements there. We've also gathered a collection of open source resources for folks to access to build knowledge and skills for each of the 7 framework phases. And so to access that and more, we encourage people to save and click on the link that I posted to access the interactive site for the framework.
Okay, thank you very much. Would there be available courses that would also teach the framework where there will be a certificate that the participants might be interested in taking or something?
That's a great question. Dr. Joe Tucker, I'm going to ask you to answer that one.
Thanks. I was just about to say, wait a second, I've got an answer to that one. Thanks for the presentation, Liz, and it's a great question, Carissa. There's a couple of points. One, if you go to the website and there's a link in the chat to the website, there's actually our sort of recorded version of the 1-hour webinar that goes into more detail. So what Liz just presented is sort of a brief overview, but there's a much deeper 60-minute sort of workshop that's recorded. And in addition, there's going to be Dr. Pakri and Dr. Chen have kindly agreed to do another kind of similar training workshop in December for a group in Bangladesh. And if anyone is interested in joining, you can email me or Dr. Chen, and we can make sure you get the information about it. Over.
Thank you very much. Maybe you can write your email address in the chat box so that we can, our participants who are interested in enrolling can send you an email. Thank you for posting your email address, Dr. Chen. So we have time for one more question. Maybe your participants would like to ask our three speakers or even the innovators earlier, if you have any questions. Maybe, yes, go ahead. Okay, maybe I would just like to ask also Dr. Wei-Ming Tan. I know for crowdsourcing, you were offering, maybe we have participants who would like to learn or have a mentorship with you. Maybe you can share with us that as well.
So actually, yeah, if anyone want to use crowdsourcing, we actually have lots of resources. We have a crowdsourcing practical guide open to share with anyone. We also have like lots of training sessions before, including in this year, we have a specific 2 4 hours training session. We have we can also share the website of that we still later on. Joe is actually putting the practical guide link into the chat box. I think if anyone want to know more crowdsourcing, please, you can click into the practical guide. This practical guide was published in 2018 with the TDR Global. The aim of this practical guide is actually to facilitate the use of crowdsourcing in different fields. Yeah. If you also want to conduct any crowdsourcing contest, you can also reach us. We have crowdsourcing clinic. We would like to provide a free counseling service to all of you.
Oh, wow, thank you very much. Maybe some of our participants would really want to learn more about crowdsourcing, especially in this time and age of social media. It's very useful to gather information and to do implementation research also using crowdsourcing.
Yeah, thank you.
Okay, thank you very much to our three speakers. If ever you have questions for the participants have further questions, you can send them the email. They have typed their emails in the chat box, and they have also shared with you their contact details during their presentations earlier. Okay, so to close our very eventful session for today, I would like to introduce Dr. Noel Huban. Dr. Huban is the country hub lead for the SIHI Philippines and the lead for SIHI Secretariat Global Network. He is a professor of clinical epidemiology at the University of the Philippines College of Medicine and serves as the director of the country's newborn screening reference center. So let us all welcome Dr. Noel Huban.
Okay. Good evening. Good day to everyone. I think we all can all agree that we have a good discussion and exchange of experiences for the past 2 hours, and we'd like to thank everyone who are here, especially our speakers and our resource persons. And just shows that things are happening despite the, with regards to social innovations, even before the pandemic and even now as we tackle our challenges during the times of pandemic. And aside from the innovations, we don't stop in identifying the innovations that we are doing. We have to continually improve on that, and we need to document it. And there are some ways that were discussed as well on how to do that. And we look forward to sharing more of the experiences of the innovators through SIHI. And you can visit the website of SIHI, wherein you can see most of the innovations that are being that are documented at the global level and at the country level. And we look forward to our next sessions with you, who are in terms of our works in social innovations in health. I think that's all, and congratulations again, and thank you very much for all of us who are here and for our speakers for sharing their works with us. Thank you.
Thank you very much, Dr. Huban. So before we would be closing the program, we'd like you to answer our evaluation form. The link will be posted in the chat box. So kindly answer it so that it can help us improve our future learning sessions. We would like to thank again our partners from the different SIHI hubs, TDR, SESH, University of Gadjah Mada, Derby Foundation, SIDA, and the University of the Philippines. Also, thank you to our TDR grantees for attending the program. We hope you can use some of the strategies shared in today's lectures. Thank you to our presenters and innovators and speakers for all the wonderful learnings that you have shared. So also thank you for the technical staff behind the scenes for a smooth sailing learning session. Thank you to all our participants who are with us both in Zoom and in YouTube. So please take care and keep safe. Everyone, please have a wonderful day ahead. Maraming salamat po. Thank you very much.
Thank you.
Everyone. Nice job, Carissa. Great
you.
job,
Thank you
SIHI
all.
Secretariat. Yay.
Hi, Joe.
Thank you so much.
Hi, Odi.
Hi, Noel. Bye.
Hi, Yudi.
Thank you.
Hi,
Bye.
Wemi.
Bye. Beatrice.
Thank you.
Hi, Anna.
Hi, everyone.
Nice to see you, Hannah.
Nice being here.
You're a champion.